hear me at the back? Great, thank you very much indeed. So, as you can see, my name is ffrench-Constant. I'm Pro-Vice Chancellor for the Faculty of Medicine and Health Sciences, and it's a fantastically exciting day and such an important part of our strategic thinking, so it's really good to see all of you here. An observation would be that you're all sort of on that end, but actually I understand that most of the presentations are going to be from here, so perhaps when you come back it might be a good idea to move over to the other side. Okay, so as I said, I'd like to welcome you to this really exciting meeting co-hosted by the UEA Health and Social Care Partnership and by the Citizens Academy. And these two initiatives are key components of our efforts to ensure that our research is relevant and addresses the key priorities that all of our stakeholders in the region want to see addressed. So, for example, we will see a very big increase in our ageing population. We have the challenges around coastal and rural communities. These are key research issues, and it's very important to all of us that we make sure that we talk, we think about how we can together best address these priorities. So, as the focus of health and social care research moves ever more to sustaining health as well as treating disease, and this theme of sustaining health is going to be something that we will be really pushing much harder at UEA than perhaps we have done in the past. The co-production catalysed by this partnership and the way that we can work together to establish priorities, scientists, stakeholders, patients, public, everybody working together is really critical. So I'm really very much looking forward to this day. I'm sure all of you are as well. Thank you for coming, and I'll hand over. Thank you very much.
Thank you very much, Charles, for that opening address, and a very warm welcome to you all. You'll notice that Caitlin and I are wearing pink, and pink represents key colours of both the UEA Health and Social Care Partners and the Citizens Academy. So my name is Carrie Jackson. I'm an Associate Professor and Research Director for Health and Social Care Partners, and I'm joined by Caitlin.
Hi, thank you, Carrie. My name is Caitlin Notley. I'm the Director of the UEA Citizens Academy. It's really fantastic to see you all here this morning, so thank you for coming.
So we're just going to do a little whistle-stop tour about what we do here. So I have a fabulous team that works with me in the Health and Social Care Partnership. They are Heather Judson, who's our Communications Officer, who's loitering at the back of the room. Bianca Bianchi, who's down here at the front with the lovely pink hair. Sarah Walker, who's up the back, who's our Business Manager in pink. And Kieran, a boy who's kind of sporting pinky blue hair and a salmon shirt at the front here. And together, we really work very hard with health and social care organisations, private public sector, charities, local government, to build capacity for health and social care research and innovation that is practice-led, that matters to people. And we do that by working very closely with patients and citizens, and hence the Citizens Academy is absolutely critical to our partnership work. And later on this morning, you're going to be hearing a pre-recorded keynote address from Professor Sir Michael Marmot. And one of the things that he talks about in his Marmot principles is the importance of hope. And he says that to be truly radical is to make hope possible at a local level. And I firmly believe that the initiatives that Caitlin and I are engaged in with all of you here today actually provides hope that our health and social care organisations, our services, can improve both population health and patient outcomes for our region. So, we fund practice-led research and innovation, and it's very much about ground-up, bottom-up, practice-led research. So we're really supporting initiatives that help practitioners with great ideas to come to us for support to develop those great ideas into funding proposals, and we then support them through the consortium. And the consortium consists of organisations across Norfolk, Suffolk and North East Essex. And we've been working together now since April 2019, but I would say that the biggest impact that we've had probably is since last January, when we changed our focus significantly to focus on practice research as opposed to academic research. So we do this through a number of different initiatives during the year, and this is just a little snapshot from our fabulous website, which of course I'm showcasing here. But we have a range of opportunities where we fund practice-led research. So that's firstly through our partnership funding call, which happens in the spring. And then we have research sandpits, 3 to 4 of these a year, that allow practitioners to come to us with early ideas for research, and we help to pair them up with experts and citizens to help shape those ideas into potential proposals for funding that they can later come to us and apply for funding or go elsewhere to larger funders. It also helps us talent spot and catalyse ideas very, very quickly and help to put the right partners around initiatives. We have Catalyst scholarships, which enable practitioners to get their completed research either funded for publication or presented at conference or cascaded through regional workshops and events. And there will be a call again in the autumn. And we are also this year funding some collaborative fellowships with the NIHR ARC East of England. So we've got 2 improvement fellowships and 1 improvement research fellow. And that's a new initiative which we're hoping to build as we go forwards. So this conference will celebrate the projects that have been funded in the year 2022 to 2023. So there are 10 projects that are recipients of funding that you'll be able to go and hear about today. There's also 13 scholarship awards, and there's lots of posters out in the main foyer for you to have a look at. And those are the outcomes of work that's been funded through the scholarship. We also have, I'm very pleased to say, 37 applications that are currently being screened and sifted by our expert panel, which comprises of members of the consortium through the partnership, management and executive board, and the results of those will be out at the end of July. And again, we will celebrate the impact of those research studies next year at a similar event. We like to really showcase the impact of research that we funded through case study stories, and these are some examples of some of our fabulous colleagues who are here today that appear on our website, so you can read all about the impact that the work that they've done has had on their services, their patients and their colleagues at work. So that's us. I'm going to hand you over now to Caitlin.
Thank you. So I'm just going to talk to you a little bit about our Citizens Academy. For those of you who don't know about us, hopefully you have heard of us, but if not, this is just a brief introduction to what we are and what we do. So first of all, who we are? Well, the Citizens Academy is about all of us. We are all citizens of our community. We all have contributions to make in terms of improving healthcare. We all come with our own biases and assumptions, wants and needs. So it's really important that we recognise that everyone is part of the Citizens Academy. Of course, we have specific patient and public members as part of our Citizens Academy. These are experts by experience who want to get involved, particularly in research that we're going to be focusing on today, but also in teaching across the schools of medicine and health sciences. We have a fantastic, active and agile steering group who help keep us on track and oversee the work that we're doing. And then the staff, you see here, see us all here. So Anna Varley, Gemma Richmond, Alex Ashbury and myself. We're all here today. Please come and engage with us and talk to us more about the work and what we can do to support your work. So the Citizens Academy was established really because of our shared desire across the Faculty of Medicine and Health Sciences to really improve health education and research by co-producing research, working closely with members of the public and patients and involving them in absolutely everything we do. So this is at all levels of the research process, right from the germ of a research idea, working with patients about what matters most to them, what we should be focusing on, through to delivery of research, dissemination and engagement with the public. As an academy, what we try to do is provide a central point of contact. That's for academics or for practice-based researchers to come to, wanting to work with members of the public or patients, but also members of the public themselves. We're a central point of contact. We offer support, mentorship, we have best practice guidance, we have a reimbursement policy which we encourage everyone to engage with in order that we can properly fund patient and public involvement and reimburse people for their time. We signpost to existing panels. There's some fantastic active service user groups across the region. We're not looking to overtake the work that they do, but we work together in collaboration. So we really try our best to facilitate those relationships between experts by experience, members of the public, and academics or practice-based researchers wanting to do research, and kind of linking people up together and enabling them to be able to have those relationships. Just wanted to take a few moments to reflect on some of the Marmot principles. I'm jumping ahead a bit here. I've had a sneak preview of the keynote talk that I'm afraid you haven't yet listened to. But I wanted to really reflect on what Sir Michael calls his Marmot principles, and really think about the way that inclusion particularly is drawn out in some of those principles that you will hear about shortly. So first of all, he talks about enabling all, that's everyone, to be able to maximise their capabilities and have control over their lives. This really means, involving people in healthcare decisions and in the research that we fund and carry out. Importantly, tackling discrimination, racism and their outcomes. This is incredibly important for the Citizens Academy. We work really hard to be as inclusive as possible, to make sure that we include experts by experience from all different walks of life, with all different sorts of stories to tell. And pursuing environmental sustainability and health equity together. So working in partnership, really recognising the value of experts by experience alongside experts by methodology or by academic skill, for example. So how do we achieve this? How do we really truly work together and ensure that we are inclusive and really collaborative in our approach? Well, the Citizens Academy, we're here to provide help and support to research teams to enable them to do that. We help to enable teams to engage with members of the public and patients so that their co-production efforts are meaningful at all stages of research that's undertaken. And we also facilitate community engagement. We're really active in going out and meeting people where they are, not expecting people to come to us and get involved in research, but going out into communities, meeting people in their community groups and trying to make sure that their views are equally included in everything that we do. So I just wanted to end on a quote from a piece of research that we were involved in over the COVID-19 pandemic. This was really focused on what makes us well. So as well as thinking about the inequity in society and health inequalities, thinking about things that we can do to improve health and taking a positive focus on what makes us well. So in this research, we found that participants were able to draw on assets which helped to keep them well and maintain social connections. So this means that the things that are available to them in their local communities were really important in helping to improve their health, making connections with other people, being part of community groups, reconnecting with nature, appreciating the outdoors, creativity. So the findings of this study really illuminate the different experiences and the powerful effect of those community-based assets that participants perceived as being really protective for their well-being. So as you listen to Sir Michael this morning, I really hope that you will think about all those positive aspects that support health and well-being and how we can focus on them in our research efforts. In assessing impact of the Citizens Academy, really important for us to think about what impact we're having, and we like to do this at a number of different levels. Crucially, we think about the individual level, so what's the impact of our patient and public volunteers of getting involved in the research of the faculty. Lovely quote here from Jeremy, who is here with us today, and I hope you'll go and chat with him, talking about how being involved in research is rewarding for him personally, as well as giving something back to the faculty. At the faculty level, I think we're seeing really fantastic sustained impact of participant involvement in research. This year we've successfully supported 7 major funding applications which are now active and running, and we're currently supporting a further 29 applications in development. So this is really critical. The funders not only expect patient and public involvement as part of a research application, but it is morally and ethically the right thing to do. At the university level, the Citizens Academy support the role of UEA as a civic university. I guess we think of ourselves as the bridge between the public and our community and what might have been seen traditionally as the kind of ivory tower of academia. We're hoping to break down those boundaries. And nationally and internationally, I think we're also starting to achieve some recognition, which is fantastic. UEA is part of the Aurora network of European universities, and the Citizens Academy has been used as a flagship case study of how to engage with community involvement across research and teaching. So we're really excited to be kind of leading the way in terms of our approach to involvement in research. So I'll hand back to you, Carrie, just to give everyone an overview of the day. Get involved, enjoy, and thank you for your time.
Yes, so this is a celebration conference. It's all about you, because most of you here have received some funding or are collaborating with us, so it's really great to see so many faces. So enjoy the conference, get involved. We've got to do housekeeping. We shall do that a little bit later. So if there is a fire, do go through the green exits at the top of the lecture theatre. We're not expecting any fire tests today. Okay, so I am now going to move us on to Professor Sir Michael Marmot's speech, which I'm hoping will work.
I've been saying of late that the two big challenges facing us globally are the climate emergency and the growth of inequalities. We've had successive COPs to deal with the climate emergency. They're taking steps in the right direction, but not enough attention to health inequalities globally or nationally. And that's what we've been about. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. Particularly at the time of a pandemic and when the NHS is tottering. We think a great deal about the healthcare system, but my concern is with the conditions that make people sick. And there have been 3 recent challenges in the UK to health inequalities. A decade and plus of austerity, the COVID pandemic, and the cost of living crisis. In my 2010 Marmot Review, Fair Society, Healthy Lives, and again in our 2020 report, Health Equity in England, the Marmot Review 10 years on, I had 6 domains of recommendations, Marmot principles. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4, everyone should have at least the minimum income necessary for a healthy life. Healthy and sustainable places and communities. And number 6, taking a social determinants approach to prevention. Now, we've added 2, which in a way should have been there all along. Tackle discrimination, racism, and their outcomes. And pursue environmental sustainability and health equity together. It's the way I began. We need to deal with the climate crisis and the crisis of great inequities that lead to health inequity together. This is from my 2020 report, published just before the pandemic hit us, and then updated with the next year of data. Life expectancy for women and for men had been increasing about 1 year every 4 years. In 2010, there was a break in the curve, and the rate of improvement slowed dramatically. Then, in the first year of the pandemic, life expectancy fell for 0.9 years in women, 1.2 years in men. Dramatic impact of the pandemic. What happened in 2010? We had a new government elected, Conservative-led coalition government. Is it possible that their policies, particularly of austerity, might have led to this slowdown? It's something we need to consider, because not only was there a slowdown in the average, look what happened to inequalities. So each of these represents a region. Women here, and the top set of graphs are for the least deprived decile, 10%. And what you see is the regional variation is quite small. If you're rich, it doesn't much matter where you live. And life expectancy was improving a bit over the decade. If you're poor, this is the most deprived decile. The regional differences are much bigger. Life expectancy was going up in London, but going down in virtually every region outside London. So this is where we were pre-pandemic. Life expectancy had more or less stopped improving. Inequalities, social and geographic, were getting bigger, and life expectancy for the poorest people were going down. Could it be due to the government's policies? Well, the government was quite clear of having austerity as the number one policy. And they did it, by golly. In 2009-10, public sector expenditure was 42% of GDP. And over the decade, the 42% went down to 35%. They really did cut public expenditure. They presented it as an economic necessity. And yet, in the first year of the pandemic, the Chancellor said, whatever it takes. Oh, you mean this might have been a political choice, not an economic necessity? In my 2010 review, I coined the rather awkward phrase, proportionate universalism. What I was trying to do is combine two ideas. The standard Anglo-Saxon approach to social policy is you target, you focus on the worst off, means-tested benefits. A more Nordic approach is you have universalist approaches. I tried to combine them. Said, let's have universalist approaches with effort proportionate to need. We could call it levelling up. So here's the social distribution, the gradient, less deprivation, higher life expectancy. If we focus only on the most deprived, we may help them. But what about these people whose health is not as good as those up here, but would be missing out by this targeting? So let's have universalist policies with effort proportionate to need. What did we get post-2010? This is spend by local government per person. In the least deprived 20% of areas, the spend per person went down by 17%. And then the greater the deprivation, the greater the reduction in spend. In the most deprived areas, it went down by 32%. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Could this have played a role in the slowdown in health improvement, the increase in inequalities, the decline in life expectancy in the poorest areas? Yeah, I think it could. If you think, as I do, that a lot of what local government does is really essential to people's health and well-being, then cuts of this magnitude must have an effect. So we had a decade and more of austerity. George Osborne says there's a simple truth. If you have a very large crash or economic crisis, the country pays the price. The basic truth is a country has to live within its means. And he said, this is in the public domain from his COVID testimony, the economic policies we pursued after 2010 meant that we actually had the strongest growth in the G7. More jobs were created, a lot to be proud of. Britain in 2016 was buzzing. People were looking at the UK and saying, that's the example we want to follow. Really? Really? UK real wages are lower today than 18 years ago. There's 2010. People were looking at these peer countries, and we just slipped down and down the ranking. And all these countries looking at this decline in the UK said, gosh, we wish we could be like that. This is the change since 2009. And his peer countries. Really? Who was looking at us and saying, we wish we could be like that? None of these countries were. And austerity made deep and lasting cuts to public spending. Total government spending, as I've shown you, went down. Government spending on healthcare, percent of GDP, went down. And spending per person, adjusting for aging of the population, declined. And it had impacts. If you take January 2009 as the benchmark, the number of people waiting for NHS treatment. In 1997, there were 2.3 times as many people waiting for treatment. It came down dramatically. By 2019, it had doubled. This is pre-pandemic. This is pre-war in Ukraine. This is pre-cost of living crisis. Look what happened to the number of people waiting for treatment. My goodness. The share of A&E attendees seen within 4 hours, it was up to 98%. And now it's below 60%. It's hard to say that the policies of cutting total government spending and healthcare spending had nothing to do with this. And then came the pandemic. We said from the beginning that the pandemic would expose the underlying inequalities in society and amplify them. And so it proved. Here's the social gradient in all-cause mortality and the social gradient in COVID-19 for men and for women. The social gradient's very similar. So it exposed the underlying inequalities in society. In fact, the gradient is slightly steeper for COVID-19. And if we look at life expectancy overall for the 3 years 2018 to 20, compared with the previous triennium, life expectancy fell not just for the poorest 10%, but for the poorest 40%. In fact, for men, it didn't go up at all across the gradient. For women, it went up for the top 60%. But the greater the deprivation, the greater the decline in life expectancy. We were in a poor state pre-pandemic, and the pandemic made it worse. And then the cost of living crisis. If you're in the richest quintile, this was the proportion of housing household consumption spent on essentials, which covers food, fuel, clothing, and transport. That went up a bit, 2012 and 2019. If you're in the poorest quintile, it went up a lot, which means there was very little flexibility in the system. If prices went up and you were poor, you were going to be in real trouble. And that's what happened. Look at food insecurity. In January 2023, 1 in 6 households had food insecurity. And for households with children, it was 22%, somewhere between 1 in 4 and 1 in 5. Households with children were suffering from food insecurity, having smaller meals or skip meals, being hungry but not eaten for a whole day because of cost. And working age adults in poverty. This is working families. So if you look at the southeast, it means of the adults in poverty, 2/3 were in families where at least one adult was working before housing costs, and after housing costs, it was more than 70%. In other words, work was not the way out of poverty. The majority of people in poverty were in households where at least one adult was working. So that's the national picture. Pretty depressing. What to do? More than 40 local authorities have declared themselves Marmot places. Coventry, a Marmot city. We did a report for Greater Manchester, for Cheshire and Merseyside, Lancashire and Cumbria, Luton, Waltham Forest. We launched Leeds a couple of weeks ago as a Marmot city. I did point out to them in Leeds that Luton had been a Marmot town for at least a year longer than Leeds, and Luton got promoted to the Premiership, unlike what happened to Leeds. Coventry, Marmot Steering Group, all of these different players in Coventry are all part of the Marmot Steering Group. So it's local government, but it's public sector, the voluntary sector, all the different elements. We were approached by a big corporation, Legal and General, to ask what could business do to improve health and reduce health inequalities. And we drew on some of the experience Coventry, a job shop, so helping people into employment. Luton's vision, I won't go into it. Might we get changed nationally? Keir Starmer unveiled Labour's health pledge, and they had a technical document that said the next Labour government will amplify the approach of Marmot cities like Greater Manchester and Coventry by making England a Marmot country, tackling the social inequalities that influence health. Wow. What about healthcare? The East London Foundation Trust said, well, we can build on the report that we did for industry, where we talked about improving conditions for workers. And the East London Foundation Trust said, yeah, we can be a good training and employment provider. the quality of goods and services, and the wider impact on the community and the environment. And this was our review for industry, the business of health equity, the Marmot Review for Industry. And here are the three elements: paying conditions, goods and services, and partnership working, and impact on the environment. Social justice and better business. And we've now created a health equity network. We've got more than 900 members from all around the country, with the aim of sharing expertise, learning from each other's experience, and who knows, maybe that would actually feed through in the ambition of a new government to make England a healthier place. To be truly radical is to make hope possible rather than despair convincing. And I think this local action is indeed making hope possible.
Thank you, Professor Sir Michael Marmot. You very kindly recorded that for us because you couldn't be with us today in person. While some of the messages might be slightly depressing, it does, however, make us even more determined to collaborate, develop strong partnerships, and make sure that we are doing research and innovation that's place-based together to make a difference to local health and social care services and population outcomes. So, thank you. Would you like to join me to thank him? So, I'm absolutely delighted next to welcome Mr. Phil Ward, who is going to chair a panel of esteemed invited guests to talk about the key messages from Professor Sir Michael Marmot's address. And Phil is the director of the Eastern Academic Health Consortium, Health Research Consortium, and we're delighted to have him here today. So Phil, I'll leave you to introduce the guests.